So my topic basically is MI in the COVID scenario. So let me start first by just a general introductory slide. We as cardiologists, interventional cardiologists, believe that when we talk of acute MI, the first thing that rings a bell is this patient should be on the cath lab table as soon as possible. The artery should be open as soon as possible. So this is the goal that we kind of work on in acute MI. Now, if you see this slide, essentially, I'll just move this here. So if you see this slide, now we know that the pathogenesis of this COVID-19 virus, it causes the respiratory symptoms are most predominant. There is a pro-thrombotic, pro-inflammatory milieu, and that is responsible for majority of the extra respiratory manifestations that we see. A tendency to be in a hypercoagulable state, and also a direct injury to the myocytes, to the endothelial cells. Now, this manifests itself in the ways that Dr. Juwale sir just mentioned, which I am just going to brush up. The first one is a type 1 myocardial infarction, where there is a proper plaque rupture occurring inside the artery because of the endothelial, because of the plaque sort of thrombotic milieu, etc. The plaque, stable plaque may just rupture, and that can give rise to thrombotic occlusion. There's a type 2 acute MI, where these patients are basically, as Dr. Talat mentioned, they have a demand-supply mismatch, a severe acute respiratory distress syndrome, severe sepsis, and this patient, suddenly you see the ECGs, the ST elevations are there, and this patient, if you take to a cath lab, most likely you will see that the angiography is normal. The third one is acute microvascular dysfunction, and that can manifest as a stress cardiomyopathy, as Sir mentioned about Takotsubo syndrome. The fourth one, this is relatively common, is the myocarditis variant, where we see a patient who is had a respiratory ailment, suddenly becomes very unstable hemodynamically, and when we do an echo, we see that there's a global motion abnormality, the heart is not contracting well, and it leads to a myocarditis. We have even seen patients who are coming with fulminant myocarditis. Literally in a span of maybe 24 to 36 hours, the patient is suddenly on all supports. So these are the various kind of manifestations that we see. My understanding for today is that I'll be speaking only on myocardial infarction in the present scenario, and that too with regards to how we have changed our practice with respect to COVID-19. All this time, as I told you, our focus was just on getting the patient early to the cath lab, opening the vessel and saying that yes, things are good. But for here, there has been a little bit of caution once COVID-19 came, and I'll tell you why exactly we do this and how we do it. So if we see this COVID-19, now majority of our data comes early from the Wuhan counterparts who are there in China, and they were the ones who told us that yes, cardiovascular disease, diabetes, these are the two red flags, that if you have these two conditions, you do not think of self-isolating yourself, you should be in the hospital, because morbidity, mortality is maximum in this two subset of patients. Now, when we talk of myocardial injury, as Talat mentioned, that if you do in patients with moderate to severe COVID, if you're going to do a TROP, you will get a very good idea of how your patient is going to do in the next few weeks. Now, this was the curve that they saw again in Wuhan, this was, and if you see the blue curve is the one in which TROP was normal, and the red sharp downtrend that you're seeing of survival, which is coming down rapidly, is in the patients who were COVID or TROP positive. So clearly this shows that there's a very precipitous decline in the survival rates once your troponin is positive. And this is one of the reasons why the guidelines have been telling us that cardiac disease patients should be in the hospital. So let me go first to the start around in March, mid-March, or I would say for us, March 25th. We were all worried with this new pandemic that suddenly broke into the news, and we saw that majority of patients just evaporated. There were no MIs happening, there were no primary PTCAs happening, there were no primary PCIs, very few patients getting admitted to the hospital in trickles, and even for us, once the lockdown was announced, we saw that there was a lull. There was absolutely no admissions happening with regards to ST elevation MI, and we were left wondering as to what can be the cause, to the extent that we thought maybe this pandemic has modified things so much that patients are more stable, they are at home, stress-free, so probably that is why the MIs have gone down. If we see in Europe, that's where our data comes from, majority is from Europe, there was a significant drop in all diagnostic procedures. And they have a very extensive ST elevation myocardial infarction care network, where all patients are immediately wheeled to the cath lab, and they have commendable work done in terms of speed of opening arteries up in acute myocardial infarction, you can see there was a significant drop in diagnostic procedures, even elective procedures, structural heart disease, and even in patients who were taken up for a primary PCI. Now, by primary PCI, what I mean is patients who are wheeled in a heart attack or acute MI where we did a primary angioplasty to bail out the patient from this crisis. There was a 40% drop in Spain. This correlated well with almost everywhere. If you see, this is the chart that shows us from March to May. You can see the Asia, that is where I've shown the arrow. Almost 39% of patients had reduced compared to usual numbers that we would see in January or February. So the question was, where were these MIs? Even by the time these patients started presenting, and we did see a lot of them come back in May, and we saw that the numbers increased drastically, especially those who are COVID positive. And you can see that nearly 33% of them came far beyond their actual time of presentation. If you have a patient with chest pain, and if we go around telling that this patient should seek medical help at the earliest, we realize that almost 35 to 40% of these patients were not seeking help at the right time. They were coming in late. We wanted to know, why is this late? Because all this time we have been saying that golden hour is very important. Within the first 60 minutes, the person with an acute MI should seek medical help. We have clear-cut guidelines and framework by which we work, and you will see that the door-to-needle time, that means the time from which the patient enters the hospital to the time he is getting thrombolized, should be less than 30 minutes. The door-to-balloon times from the time of emergency contact to the patient undergoing an angioplasty or the balloon opening in the vessel should be less than 90 minutes. The total time from the symptom onset to the time that the artery is open should be less than 120 minutes. So we have this kind of, frame set guidelines. We try to fit the patient into these guidelines so that we know that time is muscle and we must secure the myocardium here. And this is what our problem with COVID is, that COVID just upset this whole balance. Everything, everybody was challenged, and the whole sort of a healthcare system collapsed. And we realized that we were not able to reach these kind of guidelines and these kind of timelines, essentially, because of certain reasons. And this was what we saw, that when we talk of STEMI, this is data from Europe. And you can see those three arrows which I have shown, that there was an increased delay in reperfusion related to COVID-19. So these patients were getting thrombolysis late, or they were undergoing PT's primary angioplasty late in 48%. That is quite high, 1 in 2 patients. Patients were given thrombolysis because of logistic reasons. The hospital suddenly became full. There was no beds available. So 22%, 1/4 of them received thrombolysis instead of primary angioplasty. And mind you, in Europe, it's a very good network of angioplasty in acute MI situation. Now comes the third answer. Where were all these patients from March? We saw that these patients were all at home with symptoms, didn't show up because of the pandemic, and suddenly they came back on the second or third week with cardiogenic shock or some mechanical complications related to the myocardial infarction. So this is how COVID-19 upset the entire situation with regards to patient presentation. What really changed because of COVID? One thing is, of course, the delayed attention due to lockdown. The patients did not seek attention. Patient also had some sort of lack of transportation. Suddenly all autos are off the road, all local transport is off, no trains, no buses, nothing. Patient is not even aware of the nearest healthcare facility. If you had to dial the so-called government helpline early in April, you would realize that it was a total farcical way of reaching yourself to the nearest healthcare facility. These kind of things were a little difficult. Then there were healthcare factors, because there was lack of routine medical services. Suddenly doctors were not there and nurses were challenged, and there were very few of them. Now, there was a fear of infection, that, if I go to hospital, I'm likely to catch infection, that kind of fear. Some hospitals have protocols. Of course, now they are much better. In the initial April period, it was total mayhem, where the patient had from acute MI, and we are talking of a patient, we have to meet that guidelines of 30 minutes, but this patient is taken for a chest CT so that we know which hospital he goes to first if there is COVID. There was no rapid test for diagnosis. These patients were all, we send the PCR swab, wait for at least 24 hours. So we really don't know what is his COVID status. Unprecedented staff and bed issues. Then there were those enormous diktats that came that this patient this is a COVID facility, non-COVID facility. Patient coming to the emergency department suddenly had, instead of, a thrombolysis, he suddenly received a saturation probe in his hand, wheeled for a CT scan. So, the prioritization was occurring very late in the ED departments, and understandably, it was quite clear. Now coming to the cath lab. Once this patient, we decided to take this patient for an angioplasty. What are the infection control protocols? Wearing a PPE, donning and doffing takes quite a bit of time if you have to be perfect. Plus the cath labs are all with positive pressure. What is the sort of infection that we are extending around us? And Dr. Juwale sir will agree with me and Dr. Kumaraswamy that once you put a PPE, it's an experience you will never forget doing a procedure in. You tend to sweat buckets and there's totally, absolutely your concentration levels are not the same as you would have it without a PPE. So these all dynamics change, acute MIs totally. And then we realized that maybe we need to rework this thing again in a better way so that we can tend to these patients in a better way. So we thought of this, why not back to thrombolysis? And these are not my guidelines. I'll be telling you the guidelines that are there. Now, it became very funny because early in 2020, we tell you that interventional cardiology has now made a quantum leap. We have new devices, new drugs, new stents, and we are almost reaching to where the surgeon is, giving such good results, everything. And here we are in April where I'm telling you that we are back to thrombolysis. So it becomes kind of a sort of a contradictory thing which I'm saying. But I'll tell you what exactly is the thinking behind it. So you need a fast reperfusion method with minimal exposure to healthcare staff. Today, if my staff gets infected, I know I have to, again, the whole team gets quarantined for the next 14 days. We do our test, everything. So naturally, we are not able to tend to the next group of patients that gets admitted. So we needed to find some faster reperfusion with minimal exposure to healthcare staff. We had to make use of proper resources. Remember, these are times when even corporate hospitals have been challenged with regards to their finances. So use of PPEs, use of all other things became a little bit of a challenge. Plus, you have to have a hospital which has a dedicated cath lab with a negative pressure ventilation. Now, where do you have two cath labs of which one will be like this? It's a very difficult scenario. So even if you have a COVID positive hospital, it may not have a COVID positive lab. You will be putting stress on your existing infrastructure and machinery to, sort of take these kind of patients on the table for an angioplasty. So that got us thinking that maybe we go back to where we came from and think about a pharmaco-invasive approach where we thrombolize this patient first and then we get our act together, make time available, everything, see the COVID swab report and then take this patient up for a invasive strategy or for an angioplasty. And this was the data that came out from JAC, which confirms that, yes, we are correctly thinking on the correct lines. This was in the patients when they present in the emergency department, you need to divide them into two categories. One is COVID positive or COVID suspect cases. By COVID positive, I mean these are patients who are having a swab which is positive or a CT which is suggestive, or probable or suspect, that is a patient who's having a history of fever or somebody in his family has a history of COVID. This patient goes into a different category. And you have the yellow category here, you can see where COVID possible. Now remember, all patients who come with acute MI will be COVID possible unless and until proved otherwise. So this group of patients are generally no fever, nothing otherwise, but yes, possible to have COVID. So we treat these two patients in a little different manner. Now, this is the CSI document from Cardiology Society of India, which we endorse, and this is also put by the Society of Cardiovascular Angiography and Interventions USA, that you divide the patients into three classes, A, B, and C. A, as I told you, is a confirmed patient. B is a suspect patient. C is a normal patient. That means he's a possible patient, but he's not otherwise a very high-risk patient. So these patients with group A and B, if they have a ST elevation myocardial infarction, thrombolysis is the prudent option. It should be tried first. Even if your patient is unstable, try thrombolysis first. Now, they also have a rejoinder there in the next statement that I'm making, that those presenting within 12 hours, if the patient is at high risk, please take the patient for primary PCI. You can do an angioplasty, but remember what I've underlined is with the necessary precautions and preparedness. There is no point in me telling you that, yes, I will do a successful angioplasty if my team and the hospital machinery is going to take 10 hours for this patient to come to the cath lab table, do CT chest, do all this. It's not going to really make a difference to this patient. I would rather thrombolize this patient with a thrombolysis and then make him stable and take him to the cath lab. So this was the thinking with which we thought about this for group A and B. Of course, if it's a stable, non-STEMI patient, we stabilize this patient, do a COVID, etc., and then we take him. So that's an altogether different subset that we talk of. Group C, as I told you, is a patient with a very low clinical probability. He should get a primary PTCA, as is advised in all patients that you take for interventions in acute MIs. So group C, you would definitely look at that. What happens to, now these were the guidelines that we talked, what happens in countries like India, and sadly we have been caught off guard, no doubt, the healthcare system we have seen in the last few months, and what happens in country, in our population with rural or urban setting where we have absolutely limited resource settings. What do we do? So these are the kind of guidelines that if it's a low risk STEMI patient, you consider thrombolysis as a treatment of choice. Now, again, in patients either confirmed or suspect, that is your group A or group B, both, you will consider thrombolysis as the treatment of choice in these patients. Now, I'm talking of, these are all patients who are confirmed and suspected. I'm not talking of the group which is possible. There you will, of course, go for primary PTC in those patients. Now, your selection of patients that you take for this patient has to be very, very careful when you come across. For example, if I see the topmost one, that is non-ST segment elevation MI, I am not going to risk the team. I am not going to risk the people in the hospital by taking this patient directly to cath lab. This non-ST segment elevation MIs can be managed conservatively with medical therapy, and then you may take the patient up later once you have the COVID report. Now, suppose this patient has a troponin positivity, myocarditis, without any cardiogenic shock. You have noticed some amount of tachycardia which has set in, some amount of hypotension. You have done an echo, and the echo shows that there is a global LV dysfunction. It's not pertaining to any particular territory. This is a patient, again, that I would keep on medical treatment. I would not think of taking him to the cath lab. The third group, where a patient is just elective. This patient has just walked in saying that I want to do an angioplasty for this patient, and this is not really the need of the hour at this stage. So elective procedures, we keep them out totally so that we don't strain our existing infrastructure. Type 2 MIs. As I told you, type 2 MIs usually happen when the patient is in full-blown sepsis or, ARDS or so, where this patient is likely that, because of the demand-supply mismatch, he may have ST elevation. Again, this patient, when I take to cath lab, our experience has been they have non-obstructive coronary artery disease. It's just small thrombi which are seen and which we don't do anything about. The flow is good. These patients should not be taken up to the cath lab. And the last group of patients, STEMI patients who are doing very bad, who are in severe pneumonia, and these are patients where I would not take to the cath lab at all, because we do not know whether he will outlive the procedure or not. So there you have to be very careful about this patient selection on what type of patients you take. And these are some of the general principles. As I told you, low risk patients you will consider for fibrinolytic therapy. You will go for fibrinolysis, you will transfer this patient to an isolation ward, and then you will consider him for an angioplasty if needed. Now, what happens to high-risk patients? Now, as much as I tell you that we are not keen on doing these patients, but they are patients who need urgent attention, systolic blood pressures 90 and lower, urine output grossly oliguric, and they are kind of going in a sort of a myocardial jeopardy where you have to take this patient on table, and life-threatening arrhythmias, yes, you will take these patients, and you will make sure you don a PPE suit, you will make sure that you have adequate personnel, and you take people only that are needed, you don't take additional people. You do everything bedside as far as possible. IABP insertion, temporary pacemaker wire insertions, all these to be done bedside. You don't take them just for that to the cath lab. Again, use of PPE, etc., use of primary angioplasty only to the culprit. You do your job and come out. That's it. Nothing more needed for such patients. These would be the high-risk patients that you would take. Again, some do's and don'ts, which I will not go into too much detail, but remember, intubation in the cath lab is going to be a little disastrous. Better intubate this patient in the ICU under controlled conditions and then take this patient to the cath lab. Personnel who are not needed in the cath lab. For example, I need only a circulating nurse, a scrub nurse, there's 2 or 3 people, 1 anesthetist is all that I need. These are the only patients who will be in cath lab, others will not be taken inside. Again, guidelines, as I told you, it has to be a negative pressure ventilation, but we don't always get that kind of negative pressure ventilation. There are guidelines that have been put that there should be HEPA filters. This AC unit of the cath lab should not be connected to the hospital AC unit. It should be separate. But again, these are wishful thinking. We don't get these kind of hospitals and these kind of healthcare systems anymore here in India. So this is the kind of problem. Personnel management. Always do not take staff who are elderly or patients who have comorbidities, hypertension, diabetes, etc. Don't take these patients with you to the cath lab, because they are likely to get COVID or so, and they are likely to sort of hinder their or their family safety in that case. So very imperative that we follow this. We follow alternative staffing modules. You create units. And this is what we've been doing for the last 6 months, is in one hospital, we have delegated ourselves to one person, one junior colleague, one senior colleague, 2 or 3 nurses who are in that unit who will take care of that week. And next 2 weeks, they will be off. So that way they get a time to quarantine themselves also if they get that kind of an exposure. Has worked well, but unfortunately, yes, there have been hits and misses here also. It's not always the best thing to do, but in such challenging times, I think this is the only thing that we can speak of. Now, with all this talk that I gave, has it been validated? I have quoted the JAC guidelines. I have quoted the guidelines from CSI. But this is not what we are doing. This is what world over people are doing. Now, as you can see, this is from Manchester in UK, that this is an article taken from circulation which says fibrinolysis or thrombolysis may be the best compromise that you may have at present, where you will have a least resource implications for your institution. And, at such a time when we know that optimal care strategies may be very challenging in the pandemic. So we may not actually go for primary PTCA. You may just think about thrombolizing this patient. It may be good for you and the hospital as well as the patient. Similarly, our Italian colleagues, etc., similar publication in JAC 2020, where they also have said the same, that you need to select your patients very carefully if you're going for any urgent or emergent procedures. So clearly this tells us that, we are on the same page around the world, even though they may have the best of equipments, the best of EMS equipments and, mobilization, but it's been a challenging time for everybody, and we will have to accept the new normal. Now, as I told you, this initial part, this presentation that I made, these are arbitrary recommendations. This will change next month or maybe next to next month. We will get acclimatized to this new normal, but we know that hospital resources are getting slightly better and better. They are getting maximized. So our pattern of practice is likely to change in the next 3 months, and we will again go back to doing primary angioplasties, etc. Once we realize that we are, we have maximized our workforce together to deal with this kind of situation. Now, what I told you was about March to May, when we came in for a sudden shock and we realized all these MIs coming in suddenly like this. And we must give some credit to the government response, because it's been really great. But in the face of a healthcare system that we have, it's been really good. But did lockdown really help? I really don't know. And this question is open to the jury. Role of chemoprophylaxis, we have used hydroxychloroquine almost like anything else, but whether it works, we don't know. A lot of bureaucratic hurdles. Every time there are new amendments coming up for healthcare workers. And the funny part, ICMR refuses to accept it as a stage 3 community transmission. I really don't know why and what, but I believe the criteria is not, concordant with countries like India, where you may not have this. But, this pandemic has clearly put us, the classic Hamlet dilemma which you have for policymakers, and I don't blame them, where you put lives and livelihood at the same time competing with each other is going to be a very difficult time. And I just hope and pray that all of us stay safe and we are able to render our duties the same way that we were able to do prior to this pandemic. Thank you.